Astonishingly, after a median follow-up of 10 years, the prostate cancer-specific mortality, which was the primary endpoint of the study, was only 1%. And that's amazing. We didn't expect that when the trial was set up. That's very low. And that really tells us something about the natural history of this type of prostate cancer, bearing in mind how it was diagnosed. We're taking men who were otherwise healthy, who were offered a PSA test. So these were not men who'd already presented to their urologist with symptoms. So that says something about the natural history of localized prostate cancer when it's detected in that way. Now, digging a little deeper, there's more to say about that, because although the prostate cancer specific mortality was only 1%, the overall mortality was only 10% at a median of 10 years. So it's quite a healthy population that we had. But if you look at disease progression, and by disease progression I mean clinical disease progression, which was defined in several ways, which are detailed in the main publication, there was a difference. And actually, radical treatments, curative treatments, be it surgery or radiotherapy, manifestly do reduce the likelihood of disease progression by about half. So that's a big effect, except that it's still only a phenomenon which affects a minority of men. So it's quite wrong, I think, to use PROTECT as an argument to say that we just should not be treating men with deferred treatment, they should all be immediately treated. That's not the case, because most men do not need treatment. They really do not need treatment. But whether or not it's right to defer treatment for an individual man depends on the patient's perception of the risks of disease progression and how much that means to them versus the trade-off of side effects which they would certainly get if they had immediate treatment with surgery or radiotherapy.